Welcome to Vet Fraternity. In this video, we are going to talk about one of the most important topics in canine and feline ophthalmology, that is glaucoma. So let's begin. Initially, if you want to know what a glaucoma is, you should remember this first line. That is big, blue, ophthalmic, blind eye that is painful. Basically, it sums up all of the features of the glaucoma. So the glaucoma is going to be big, blue, ophthalmic, blindness is going to be there, and it is going to be painful. So the synonyms, it is like called as like ocular hypertension, ophthalmos, globus. As name indicates, it refers to like increase in the size of the eye. So let's see the definition of the glaucoma. Glaucoma is characterized by two things. Number one, visual impairment and blindness. So it is characterized by visual impairment and blindness from damage. Now, damage to what structures? Number one is retina and number two is optic nerve. You should remember these two structures are going to be affected in glaucoma. And this damage is caused by increased IOP. So intraocular pressure gets increased in the eye and there is going to be damage to retina and optic nerve, which leads to visual impairment and blindness. Basically, if you remember the anterior uveitis, you see that this topic is whole reverse or like opposite of the uveitis, where we were having decreased IOP and here we are having increased IOP. So let's move towards the causes of the glaucoma. We have three main causes: the primary eye disease, the secondary, and the congenital. Talking about the primary eye disease, any abnormality in the drainage or iridocorneal angle. So drainage angle you can say, or iridocorneal angle. If any abnormality happens in that, the eye is going to have increased IOPs. Let me show you what iridocorneal angle is. You see this black arrow. Basically, this is the iridocorneal angle, and what happens in the eye, there is constantly influx of the fluid and there is constant outflux of the fluid. So the fluid that is inside the eye that comes in the eye, and from this iridocorneal angle it goes out of the eye. This angle should remain intact, should remain open, and because of that there will be constant outflux. But if any abnormality that happens to this angle, what will happen, the fluid is going to stay there in the eye and there is going to be increased IOP. So and increased IOP will cause increased pressure, the eye will stretch, the eye size is going to be get bigger like the big blue ophthalmic eye, and there is going to be pain. So what next written is, initially it starts unilaterally. So primary eye disease is always going to be unilateral, but within 6 to 12 months of the one eye having primary glaucoma, the opposite eye is going to have it also. This is a very important topic, especially when we will discuss the treatment, because when we see a dog having unilateral eye glaucoma because of the primary eye disease, we start to treat the second eye also prophylactically, because we know 6 to 12 months later the second eye is definitely going to have glaucoma also, because the animals have iridocorneal angles that become compromised during few years of life and eventually cause acute pressure spike. So what happens when this angle gets disturbed, when this angle gets compromised, the fluid cannot go out, there is going to be acute pressure spike and acute pain is going to be there. So this was a primary eye disease. Then we have the secondary like glaucoma due to other diseases. So there are many diseases which will start to happen in the eye, and they will in complication and as a sequela lead towards glaucoma at the end. So lens luxation, intraocular neoplasia, anterior uveitis, and diabetic cataract. The pathogenesis of one of these is here written. Like in uveitis, what we see that inflammatory debris plugs the iridocorneal angle causing glaucoma. So when we talked about anterior uveitis in the previous videos, what we say that anterior uveitis, blood eye barrier basically breaks. Because of that, WBCs, inflammatory cells, proteins, all they start to come into the eye. And those all cells and all proteins and everything basically create a plug at the iridocorneal angle, causing its blockade, and that's why uveitis leads to glaucoma. So, number third is like congenital abnormalities of anterior segment of the eye. And so, by birth, there are some animals that are going to have some anomalies that will disturb the drainage of the fluid that is in the eye, leading to the glaucoma. Second thing, most important, is talking about the signalement of this disease. So first thing you should remember, it can happen in dogs as well as in cats. Talking about the primary one, the glaucoma is going to have affect their middle age to older breed dogs. Like the age is middle age, 3 to 12 years of age. And in some breeds, the females are going to be more affected than the males. And it is rare in cats. The primary glaucoma is rare in cats. If you see female spayed American Cocker Spaniel, Basset Hound, Chow Chow Samoyed, then primary open angle glaucoma is inherited in Beagle as an autosomal recessive trait, and primary closed angle glaucoma in Welsh Springer Spaniel and Great Dane is inherited as autosomal dominant trait. But still, most important one is the one being highlighted, female spayed American Cocker Spaniel. This is the most important signalement over here. You should remember. And this age that you should remember in which the primary glaucoma happens. Talking about the secondary glaucoma, of course, it will reflect the ages in which these individual diseases happen, like lens luxation, young to middle age, 3 to 7 years, terrier breeds. Neoplasia, of course, it happens in the older animals, and golden retrievers are predisposed. Uveitis, any age, but miniature schnauzers are mostly predisposed. And secondary glaucoma in a diabetic cataract dog. Okay. And talking about the congenital one, you see that there is going to be increased IOP, or the glaucoma starts to happen soon after birth. Okay, disease types. It can be acute, it can be chronic. In acute, if the owner brings the dog to the hospital, and the vision is going to be intact. So if it's the acute disease, it is going to be have its vision. But if it's chronic disease, it is typically going to be blind and big eye, like ophthalmic eye. But still, 50% of the first eyes of the dog presented with primary glaucoma are blind at the time of initial ophthalmic exam, because owners note these things, these signs very late. Until that, the blindness has already happened when they bring the dog to the veterinary hospital. So what is the history? The history basically means what are the clinical signs that owner is going to note at home. So there is transient or constant, red or cloudy eye. So first thing is the color of the eye is going to get changed. It can be cloudy, it can be red, with below clinical signs. So like transient or constant eye color change, red or cloudy eye, with the signs like evidence of pain. And how the evidence of pain is there, that the dog is going to be unwilling to be handled around face or head, or it is going to have bleharospasm. So any of these things happening, that means the animal is showing evidence of pain. The second thing is bumping into objects, that shows the blindness, because animal can't see, so he bumps into the objects or walls like that. Increased reflection from the eye. So basically, tapetum is a layer that we talked about in our initial lecture, talking about like the anatomy of the eye. At night, because the tapetal reflection is going to be increased reflection, because in glaucoma the eyes are going to be like dilated. Then there is going to be globe enlargement, that is the eye is going to be ophthalmic. There is going to be a big eye. So that is one of the important one. So these all are the signs that are going to be the history signs. Next, as a doctor, you are going to perform the physical exam, and in the physical exam, what you are going to see are unilateral or bilateral ocular changes. Initially unilateral with the primary glaucoma disease. Then if it's an acute disease, or like the a dog is presented like in the early stages of its disease, what you are going to see is corneal edema that is going to be diffuse. Episcleral injection, which means dilated and tortuous episcleral vessel. I have already given a separate lecture on these individuals' clinical signs in my previous videos. If you are seeing this lecture in a series, you are going to well understand what episcleral injection is. Third is dilated pupil or mydriasis. This is one of the most important signs. Mydriasis, that means the pupil is going to be dilated in this case, as contrary to the anterior uveitis, where we talked about that the eyeball was like having miosis, constricted pupil. So here we are having dilated pupil, and because of that, sluggish to absent PLRs, pupillary light reflex is going to be absent. We will talk in detail what PLRs are when we will study the nervous system, each and every eye exam test. The last but not the least is optic nerve cupping. What is basically optic nerve cupping? Let me tell you this. Okay, you see this image. What happens that the optic nerve basically carries visual information from the eye to the brain. When we see the image of the eye on the fundoscope, we see this whole circle. This circle is basically the optic nerve. At the back of the eye, the optic nerve enters through an area called as optic disc. So this is the optic disc area. And this disc is normally having a cup, a depression in the center that is called, or like small central depression that is called as a cup. So this area is optic disc from where the optic nerve enters, and this central area is optic, a small like cup, optic cup, or a small depression. But when the glaucoma happens, IOP increases and that damages the optic nerve fibers. As these nerve fibers die, the cup becomes larger, creating a deeper and a wider hole that is called as optic nerve cupping. So you see this image, this cup has gotten a lot bigger, and this is called as optic nerve cupping. So this is optic nerve cupping that happens with the glaucoma. But if the clinical signs are like chronic, of a chronic animal that is presented to you after like months into this disease, there is going to be ophthalmia, there is going to be lens luxation and subluxation. Why it happens? Because as the fluid is going to be get accumulated in the eye gets stretches, zonules break, lens luxate. You can take it as an example of a balloon in which you fill water. As you fill more and more water, the balloon walls start to get stretched. They start to get stretched, the balloon starts to get bigger, and it is going to be like having tension on it that indicates a pain in the basically eye. So because of that, the zonules start to break and the lens will exit, because zonules are basically holding the lens. So this situation will cause lens subluxation or the entire luxation of the lens. Then the blindness, that is a hallmark of chronic glaucoma. You should remember it is this clinical sign that will appear in chronic one, not the acute one. Then we are having optic nerve and retinal degeneration, of course, and ocular and head pain. Then you can see these images. It is the image of acute glaucoma. You can see the mydriasis, episcleral injection. All of these blood vessels, these are episcleral injection. Diffuse corneal edema, the whole blue tinge you are having over here, hazy tinge. It basically reflects the diffuse corneal edema. This is the image taken from Merck Manual, because it is a like majority opinion that these images might reappear in exam. Then we are having the chronic glaucoma, where we are having like ophthalmos, where the eye is bulgy, corneal edema, and you can see this hazy, like hazy or opaque, cloudy like appearance. That's the corneal edema basically. Subluxated lens. You see, this lens has been subluxated, not entirely luxated, but half luxated and half uh, covering the area of the cornea. So subluxated lens and cataract. So the cataract starts to happen in this eye. And you see that bilateral glaucoma, big blue ophthalmic eyes. These are big blue ophthalmic eyes. So that's how it looks like. Talking about the diagnosis of the glaucoma, basically it is considered in any case that presents for evaluation of red eye with ocular hyperemia, mydriasis, or corneal edema. If these signs are there in the exam, in the question, you should start to think about like glaucoma in the mind. But the diagnostic test is the tonometry. Normal IOP is 15 to 25. If it's more than 25, it's glaucoma in cats and dogs. And after that, there is a third test that is called gonioscopy. Basically, direct observation of iridocorneal angle. But for that, you have to refer it to the ophthalmologist. You are never going to perform that as a general physician, that this exam by on your own self. So you have to refer this. Okay, now the most important part is the treatment of this disease. Talking about treatment, acute cases need immediate treatment to lower IOP and to restore the vision. Because we know in the initial stages we can save the vision because the animal is not blind. So we have to do the emergency treatment, lower the IOP. For that, best is to refer the case to ophthalmologist for correct diagnosis and surgical intervention, which provides better and long-term control of the IOP. So this is a very important thing. If you want to treat the dog on an emergency basis for an acute spike in the eye, it is best to refer the case. So if you see these such things in the for the specific, like eye is a specific organ. If it's questions, you see such thing like referring to ophthalmologists for confirmatory diagnosis or like surgeries that are like very specific, you must refer these cases. You should pick the option of referring to the ophthalmologist. Long-term treatment of glaucoma is frustrating as disease tend to progress despite medical therapy. So it is one of the thing you should tell the owner also that long-term treatment is going to be frustrating because the disease keeps on progressing. Treatment goals are to decrease IOP, decrease pain, treat contralateral eye prophylactically, because if you treat prophylactically, if the dog comes to you and it is in the primary eye disease that is like initially unilateral, we know contralateral eye is going to have the same disease in 6 to 12 months. But if you start to treat that eye prophylactically, from 6 months, it will delay that progression to 30 months. So the disease will definitely progress, as we have said this in this point, that the disease will for sure progress, but still the delay or time delay is going to be 6 months to 30 months. So it is something good we are having on our side, on our edge. And if we start to treat prophylactically. So these are the treatment goals. So now next thing is, before talking about glaucoma medication, you must know these points about the drugs that lower the IOP. So basically we are having two types of a drug. There are drugs that decrease the aqueous humor production, and there are the drugs that increase the aqueous outflow. So it's like the eye is an eyeball, and in that ball you are having increased fluid. Now there are two ways to decrease that fluid. Either we stop the factory that is basically producing more fluid, or we can do something that will extract the fluid out from there. So the drugs that decrease aqueous humor production are carbonic anhydrase inhibitors, that is written as CAI. For example, dorzolamide, that decreases the IOP by 10 mm. So it's like if it's like 45 mm of mercury on the tonometry that indicates the glaucoma, and you apply carbonic anhydrase inhibitors, that is dorzolamide, it will drop it to 35 mm of mercury. Or if you keep on decrease using after 35, then it will be more of a 10, almost decrease in a IOP by 10 mm of mercury to 25, and we know the 25 is the upper range of the normal IOP of the eye. Then we have beta blockers like timolol. Basically, beta blockers also decrease IOP, but they are having 5 to 7 mm of mercury, the range in which they decrease. Then we are having osmotic diuretics, that is mannitol, that decreases the aqueous humor production. The drugs that increases aqueous outflow are prostaglandins, that is latanoprost. It increases IOP by 50%. It is used as an intraocular implant that is like attached surgically in the eye, and it keeps on decreasing the IOP 50%. Then we have myotics. These are the two myotics that are commonly used in the glaucoma, dimecarium bromide or pilocarpine. It causes miosis that opens the iridocorneal angle, and IOP decrease is 25 to 30%. So you can see it is less effective than prostaglandin, but still very effective. Then we have osmotic diuretic. It has short-term control and it dehydrates, which yes, that's how it increases the outflow. So you can see the osmotic diuretic is works in the both way, decreases the aqueous humus production and it increases the aqueous outflow in the both way. So you should remember the category in this way first. Now let's move ahead. Okay, what is the acute, surgical, and chronic treatment of the glaucoma? For the acute treatment, you can use topical prostaglandins. They are good for canine glaucoma, but not for the feline glaucoma. Why is that? Because if you see in the previous video, for the prostaglandins, we have seen that they suddenly they just decrease 50% of the IOP. So in acute treatments, you can go for prostaglandins, you can go for CAI, just like dorzolamide, beta blockers can be option, or IV mannitol. But IV mannitol is the less commonly used method now. And you can also prophylactically do the treatment of the contralateral eye, normal eye, by beta blockers or CAI. You can add topical corticosteroids if anterior uveitis also present but no ulcers. So, if the glaucoma you are dealing with is because of the disease that there was like anterior uveitis and then it led to the glaucoma, in that situation, if you can add corticosteroids also, which is a treatment for anterior uveitis. But make sure there are no ulcers in the eye, because you know if ulcer is also present, corticosteroids are contraindicated in that situation. So you have, since we have studied anterior uveitis and ulcers already, now you can understand this scenario that is happening, because I have already told you how anterior uveitis leads to glaucoma, or how ulcers can be there if there is like dry eye or anything that happens. So you can relate to these things. Next is surgical treatment. You should remember all these names that are listed over here, although most important one is gonio implants, but the other options might appear in the like MCQ options. So the first one is gonio implants. These are the implants that are like added in the eye, and they basically drain the aqueous humor and they have 90% success rate. Most important one is this gonio implant. But there are transscleral cyclophotocoagulation. It has less of a success rate, or diode endolaser cyclophotocoagulation. It has a high success rate, mostly done to prolong VN and decrease the pain. So again, these names can appear, but in the exam, in the options also, but you should remember gonio implant is the most important one. I haven't added the picture of the surgeries or any detail of these because they are not going to ask that much detail. You just need to remember the names. Then we are having chronic treatment for end-stage blind ophthalmic eye. Of course, blindness has happened. It is irreversible. So enucleation or evisceration or chemical ablation can be done. What is chemical ablation? Gentamicin or cidofovir with steroid injection is inserted into the canine eye that kills the part of the eye that makes the fluid. So these are the methods you can opt for the treatment of the chronic glaucoma, because now you cannot save the eye. Next is the emergency treatment. In the emergency treatment, the first line can be like mannitol that can immediately drop. Now you can see in our this video, sorry, in this slide, although prostaglandins are like one of the most effective, like they suddenly decrease the 50% or like that, But when we talk like they decrease it by 50%, but more quicker than the prostaglandin is the mannitol will act more in less time, like so the time frame is less for the mannitol. So mannitol can immediately drop IOP and dehydrate the vitreous humor, or you can go for latanoprost or dorzolamide drops every 5 minutes for 30 minutes. Then after that, you have to recheck the IOP and see the results, how much it has decreased. Then we are having we can give per oral analgesia, of course. The dog is having pain, gabapentin, tramadol, carprofen, or meloxicam. Since it is unknown that since how long the IOP has been increased, so try to decrease the IOP immediately. Mannitol is a drug of choice here, and its early effects are seen within 1 to 2 hours and complete effects in 6 hours. That was what I was talking about. That although the tenopros or dorzolamide they decrease 50% of IOP, but they might take more hours. But the mannitol effects are going to be there just within 1 to 2 hours. So the first choice is always going to be mannitol. Then, if IOP remains elevated for 24 to 48 hours, even after we have done the above therapy and still the IOP is increased, irreversible blindness may ensue. So, irreversible blindness is going to be there, and even if patient is already blind, you have to treat at least for pain, and you can then go for like enucleation or like psychoablation that we have talked about, because IOP is not getting decreased by the big guns. You can say we are having dorzolamide like for the treatment. Even these drugs are not decreasing the IOP. That means it's an irreversible blindness. Just treat for the pain over there and then go for enucleation or like that. The options we already discussed. And other scenarios like once IOP is constantly below 20 mm of mercury for 12 to 48 or 12 to 24 hours. So you have treated and now the IOP is normal. 20 is normal. So medical management is continued. So you are not going to stop the medical management that we are having like our IOP in the normal range. No. Keep the medical management and recheck the eye periodically. Or if the IOP is still above 30 mm, it is unlikely that medical management will decrease it. Also, if the animal is blind with 30 plus IOP, pain is likely, enucleation is option. Again, I have already discussed this thing in this point. So that point is repeated. But the whole scenario is emergency treatment is something different than the acute treatment. In acute treatment, you have all options. You can go as per indications. We will talk in the next slide. But what you in the emergency you are going to have like mannitol, or you have alternating drops of latanoprost or dorzolamide, and you have to see whether IOP is decreasing or not decreasing. If it is decreasing and it is in the normal range, keep on the therapy, just recheck periodically. But if it is not decreasing and the pain, that means the animal eye is not going to respond to medical management. So you just have to do that. You have to go treat for the pain and go for the enucleation surgery. In case of multiple issues, okay, these are the indications how you are going to pick the drugs in the acute treatment, because in this slide we have talked about it. In acute treatment we can use topical prostaglandin, CAI, beta blockers, mannitols, or like we are having all of those options that we can pick as per our preferences. But how preferences are made? So in the case with multiple issues like lens luxation with glaucoma or cardiovascular compromise, CAI is most safe. So use this drug as first line of drug regardless of the cause of glaucoma. So you can see it is what drug is safer to use when cardiovascular system is compromised or there is lens luxation, CAI. Then topical prostaglandins or myotics cause increased outflow of the aqueous humor. So it is contraindicated in uveitis or anterior lens luxation. Because we know, okay, uveitis does causes glaucoma. We have discussed how it causes, but still Since these are the drugs that causes the increased outflow, so you are not going to pick the topical prostaglandins or miotics. Use any other option for that. Next we are having is beta blockers. Beta blockers are contraindicated in the heart patients and asthma patients in the cats, but in normal patients, beta blocker do not cause any change in the heart rate. Because, and why is that? Because we know beta blockers have their side effects. Side effects are like hypotension, decreased heart rate, that is bradycardia, or bronchoconstriction as their potential side effect. So if the cat is asthmatic and you are giving beta blockers for, already she's asthmatic and bronchoconstriction will happen, the animal is going to have the respiratory issues. So if the animal is having any heart issues, it is all like already animal is in heart issue and you are giving a drug that is causing hypotension or bradycardia, that's a problem. So you have to see that. Mannitol is contraindicated in cases of CHF. Okay, they like if the patient comes to you with glaucoma, but the patient is also a CHF patient, congestive heart failure patient, never use mannitol, because we all know that mannitol is like a osmotic diuretic, and what it will do, that it will bring the fluid into the blood vessels, and already in the CHF the heart is not pumping well, is failing to pump the blood effectively, and if they mannitol will pull the fluid from the tissues in the vascular system, causing increased intravascular volume, there is going to be increased those preloads that will overwhelm the already weak heart, thus worsening the even the pulmonary issues will start to happen. So all of those things that we will study in detail when we will study congestive heart failure will start to happen with the use of mannitol. And last but not the least, we know whenever we are having the any eye disease, we like put the atropine drops or anything like that in the eye, because these are cycloplegics. Also, we place these drops just like we study in anterior uveitis to reduce the spasm in the eye. So, because of any of those issues or like indications, the atropine are used in the eye diseases. But you should never use atropine in case of like glaucoma, because atropine causes one thing, atropine causes like pupillary dilation, and it will decrease the aqueous humor drainage. So we want the reverse to happen, so avoid atropine use in the glaucoma cases. So that was all about the treatment. Next thing is the prognosis. Prognosis of glaucoma is usually poor for the first eye presented with glaucoma in the dog, as disease is often advanced and refractory to medical therapy. So first eye is always going to be having chronic issue, and it will keep on progressing and not respond. But prognosis for the contralateral fallow eye is better, because we start prophylactic therapy with beta blockers or prostaglandins that will delay the onset for the glaucoma in that eye up to 30 months. So the prognosis for each eye is variable. So that was all about glaucoma. I hope you understood this topic very well, because it is very important for the paper point of view. And don't forget to like, subscribe, and share, guys. Content making takes a lot of effort. Thank you so much.